I'm Dr. David Baskin. I'm a professor of neurosurgery here at Houston Methodist Hospital, director of the Brain Tumor Center, and also director of the residency program. I want to talk to you today about glioblastoma, a deadly tumor that you're all aware of, and tell you a little bit about some things you can do to really double or triple survival in your patients. You all probably know that until 2005, the treatment of glioblastoma was surgery, followed by radiation, followed by chemo that was pretty toxic. The median survival was 9 months, and it was a miserable 9 months. In 2005, Roger Stupp and colleagues published an article in the New England Journal of Medicine describing the Stupp protocol, which you see here, and that protocol is surgery, which debulking, a gap in time, radiation therapy with chemotherapy at the same time, a gap in time, and then 6 cycles of chemotherapy, and then reevaluate and see where you are. He came up with a new drug called temozolomide, which is an alkylating agent, kills DNA. And there was 171 patients in this paper, and this became the standard of care. Now, what did this do? It improved survival from 9 months to 15 months. Not so great, and those 6 months were not very good either. However, that was the best they had, and still the best we still have, and that drug became a $1 billion a year industry, 6 months. So we asked the question at Houston Methodist, what could we do to make this better? Is there some way we can sort out this protocol and do things that will improve survival? We do a lot of aggressive things here, so we kind of reviewed our results and saw where we were, and really with the idea that everybody's hacking everything, so we wanted to hack the protocol. We wanted to figure out ways to change the protocol, to tweak it, to twist it, to improve outcome and survival. And so let me tell you what we found in brief. First of all, what we found was you have to complete the protocol. Radiation and chemotherapy is a miserable life experience. So many patients, even though they start, for one reason or another, they don't finish. They may get a low blood count, they may get an infection, they say, I don't want to do this anymore. The oncologist says, okay. If you simply make sure you complete the protocol, look what happens. So in methylated patients, the median survival is 13 months. If you don't complete, it's 30 months if you do complete. Almost 2.5 times the difference. Nobody seems to know this. We just sort of say, well, you know, the patients aren't doing well. We don't want to make them miserable. But it turns out if you complete the 6 cycles, you don't make them miserable. You give them an incredible difference in survival, much better than you'd give them with temozolomide. Remember, that was only a 6 months improvement. Now, as you know, unmethylated patients are patients who don't respond very well to chemotherapy, but if you still press on and do it, you go from 12.7 to 18.4 months. I'll point out to you that that difference is the same difference from before and after temozolomide, 6 months, which everybody's very excited about. So this is the first hack. Press on, finish the protocol, whatever it takes. Give them platelet transfusion, give them growth factors, whatever, so that at least you can complete the protocol. Look at the difference in survival, even in the bad tumors that don't respond very well to chemotherapy. Next, second thing, there's a lot of discussion about when you should start radiation. So the gut reaction is, you know, I got cancer, man. You took my tumor out. Start radiation tomorrow. And that's what's been done in a lot of places. Guess what? That's not a good idea. It turns out that if you vary the time from the start of radiation to a little over 31 days, look at the difference in survival. 23.6 months, 38.6 months. And doesn't work very well in unmethylated patients, but for methylated patients, wait. Why is that? It's because the shock of surgery produces so much inflammation and irritation of the brain that if you start right away with radiation, it's too much. So if some is good, more isn't always better. Give it a little time, let the brain cool off, and you'll get an extra, 15 months if the patient's methylated. Big difference. 15 months is the median survival to begin with. Now, here at Houston Methodist, we have developed lots of technology for radiation. So we do stereotactic radiotherapy and radiation treatment, which, as you know, is to deliver a focused beam to a very precise area. So we said, look, what would happen if we delivered the standard amount of radiation, which is 60 gray, at 2 gray per fraction, but in that last 10 fractions, what if we just focus the radiation to the residual enhancing component? Call that a stereotactic boost. Really no data about that. A few places had tried it. The results were variable. We said, we're going to try it. So look what happened. Same sort of thing. If you're methylated, you go from 21.3 months to 36 months just by adding the boost. Unmethylated, again, doesn't work so well on. But you see, you've got a bunch of hacks for methylated patients already to double or more the survival. All right, next, dexamethasone, steroids. We've always thought if some is good, more is better, right? Because brain tumor patients have seizures, they have swelling. You do radiation, that causes swelling. You do surgery, that causes swelling. So if a patient comes in and they're not doing well, we kind of say, well, let's bump up the steroids. That's the sort of almost innate natural response that we have. Guess what? That's wrong. And let me show you why. First of all, look at the difference. If in the last week of radiation, you don't lower the steroids to less than 1.2 milligrams per meter squared, which in most patients is no more than 2 milligrams, and you use a higher dose, look what's going to happen, 23.3 to 39.8. That's a big difference. And even in the end stage, when patients are not doing very well, that's our response also. Well, let's bump up the steroids. Don't do it. 23.3, 37.5. Steroids are bad. Why are steroids bad? They're bad because they reduce the immune response. And remember that one of the things about glioblastoma that makes them so difficult to treat is they make a bunch of chemical substances that produce immune protection. The immune system is trying to come in and kill the tumor, but the tumor is sending out barriers to prevent that. They're cold. We say they're cold. Add dexamethasone, you make them colder. If you do radiation and chemo, you're breaking that barrier and you're letting it come in. So our instincts about dexamethasone are totally wrong. Here's the danger in the final week. Even unmethylated patients, remember, we don't have as many hacks for unmethylated patients. Look at this. If you don't lower it to less than 1.2 milligrams per meter squared at the last week of radiotherapy, 13 months, 18 months. Again, that's 6 months difference, which was what started the Stupp protocol. We could improve survival by 6 months. Wow, big difference. Here's an interesting thing that we found. A lot of motivated patients take vitamin D. So we said, what would the effect be of vitamin D on outcome? And vitamin D does a lot of interesting things. It's a very high-level antioxidant, so it prevents damage to the surrounding brain. It's an immune stimulant. And there's a lot of literature about vitamin D and why it's a good thing to take it every day. And I personally take it every day. But we just looked at sorting it out. What happens if you use vitamin D? And look at this. In methylated patients, no vitamin D, 20.8 months, 10 more months if you take vitamin D. Highly statistically significant. And even in unmethylated, 13 to 18. Again, that's 6 month difference, almost 7 months. As good or better than what temozolomide did. Go to Costco. I'm not advertising for Costco, but go to Costco. You can buy 200 tablets for about $15. And look at what that drug does. That's the cheapest medication you're ever going to take if you have a glioblastoma. And the timing of the start of adjuvant therapy. So adjuvant therapy means, you have chemoradiation, you get chemo and XRT at the same time, and then there's a gap, and then you start that 6 cycles. If you wait more than 75 days, look at the difference, 20.7, 38.6, huge difference. And that also holds for unmethylated patients. You again get that 6 month difference. So there's a lot of hacks. Number 1, finish the Stupp protocol. Make sure you do that. Very, very important. Difference of 17 months in methylated and even 6 months in unmethylated. Supplement with vitamin D. 10 months difference in methylated, 7-month difference in unmethylated. Again, those are numbers that are better than what temozolomide did. Mind the gap. The gap between resection to the start of chemoradiation should be more than 31 days. It makes a big difference of 15 months in methylated patients. Unmethylated patients, not so much. Keep your dexamethasone low. Resist your temptation to use it when the patients are deteriorating, because you're going to make the immune system even worse than it already is. Big difference in methylated patients. And finally, in the last days of the adjuvant chemo, wait between 75 and 90 days between the end of radiation and the start of chemotherapy. You get an effect both in methylated and unmethylated patients. I hope you find these hacks useful. We certainly have. We were surprised about the power of these simple changes and how much of a difference it makes for patient happiness, survival, and good outcome. And I feel confident that if you do this, you will find the same thing. Thank you.